long-term health and family medical leave and all those kinds of things like that. So the floor is yours. Take it away.
Wonderful. Well, good morning, everyone. Thank you so much for the time. As Bobby mentioned, my name is Ashton Alvarez. John Wallen is on the line as well, and we have the pleasure and honor of serving as the trust consultants to Washington County's Insurance Fund. Thank you for joining. And like Bobby had said, we're going to spend some time unpacking some major legislation, both at the federal level, but also at the state level as well. Slide 2 is a snapshot of the agenda that we're going to dig into today. First, we had a whirlwind of incredibly impactful federal legislation, really since the onset of COVID-19 back in March of 2020. And so if you've been a part of WCIF the past years and you've had the opportunity to join in by way of the IAC, ACE meeting, or even the summit in the past, you've certainly heard of topics like ARPA, the CARES Act, FFCRA, Consolidation Appropriations Act. But since these are such big ticket items and had a really great impact on end users and on employers, some of which are still evolving today, we want to do a quick legislation and review. And then as I mentioned, some of it is still evolving, specifically to the Consolidation Appropriations Act and the Transparency and Coverage bill. Last September, we had talked about upcoming deadlines that started in 2022 and spanned over the 3-year period through 2024. Some of those items, they have already had adjustments, and some had already occurred, and then some have had delays. And so I want to spend just a couple minutes talking about where we currently sit with regard to transparency. And then we have on the agenda at-home COVID-19 tests. And so let's review the parameters around that legislation that's already in action today. Insulin affordability in Washington State. This was something that was introduced in 2020, in effect for 2021, and then ultimately has an expiration date at the end of this calendar plan year. Though I want to talk about what that actually means for 2023. There's a new bill that has been passed. And then continuing along lines with the state level, we have 2 final items to unpack on the agenda here, which is the PAL fee and then the gender affirmation expansion benefit. And then lastly, we want to take all these items that we've discussed and then show how it would apply to current and prospective WCIF medical members and how our carrier partners are responding. Next, slide 3. This is a snapshot of the various topics that we've engaged with since the onset of COVID-19 back in March of 2020, and then the resulting federal legislation that followed. CARES Act, Family First Coronavirus Response Act, for the purpose of saying it many times, I'm going to call it FFCRA. FFCRA was signed into law on March 18th, and it aimed to address private and public employers under 500 lives. And then the CARES Act, that was a $2.2 trillion economic stimulus bill that was signed into law shortly after March 27th in 2020. So as we work through both of these significant items, one major component we unpacked was the requirement to not impose any kind of cost sharing. So things like deductibles, co-pays, co-insurance, and even further than that, you can't impose prior authorization or any other kind of medical management requirements for COVID-19 on the detection or the diagnosis. And so this was prescribed for all health plans and health insurers, both ERISA and non-ERISA plans. Additionally, related to the FFCRA, we talked about 2 laws enacted that provided workers with paid leave reasons that were related to COVID-19. And these were called the Emergency Family Medical Leave Expansion Act. And then also there was the Emergency Paid Sick Leave Act. ARPA, American Rescue Plan Act. Again, I'm going to call that one ARPA. I will take advantage of any acronym with all of these names that I can. So ARPA was developed, incredibly quickly in 2021. It passed the Senate in March 6th, and then it passed the House on March 10th, and then it was signed to law that next day on March 11th. And this was a $1.9 trillion financial relief package designed to support individuals, the state, local government, also schools, and then of course businesses. This legislation, it had many components that provided extensions to the existing FFCRA credits, But additionally, it also had some notable measures that we had worked through. You may recall it was the COBRA premium assistance subsidies, and then also the expansion of the marketplace subsidies, and then the increase in dependent care program contribution limits. Then we have on here the No Surprises Act, NSA. This was a part of the Consolidation Appropriations Act of 2021. This passed in 2020, but it became effective this year, January 1, 2022. And so the NSA was passed to ultimately help alleviate issues with plan participants who received a surprise medical bill or excessive cost sharing. And I guess a typical example of this would be, consider a surgery that was performed at an in-network hospital, where then afterwards the participant would receive a bill or charge from an out-of-network anesthesiologist at the out-of-network rate, despite the fact that the anesthesiologist was appointed by the in-network hospital. You can see how that can be quite frustrating. Under the Federal No Surprises Act, you'll recall that there were 3 covered medical billing scenarios. So it was emergency services, it was non-emergency services, but then also it was on out-of-network providers at in-network facilities. So much like that example that I just shared. And then non-network air ambulance services as well. Then we have the Transparency and Coverage Bill, TIC. Q4 last year, we outlined at the time the upcoming parameters that were set to go live January 1, 2022, so just a few months ago. We've already had a few developments that address that and a couple of changes and delays. And so we'll dig through that here in the next few slides. Additionally, on there, you'll see a bubble for the expanded 213D eligible expenses. The CARES Act, it also restored the ability to use HSAs, FSAs, HRA funds to purchase certain over-the-counter drugs or OTC medications, along with menstrual care products and also PPE, personal protective equipment. And that would now then be considered an eligible expense. One thing to remember about this is that it had actually a retroactive effective date for these expenses. So they became eligible back in 1/1 of 2020. And then last, Washington Long-Term Care CARES Act. Big breath here. There's been so much discussion on this topic. I'm sure there are a lot of heads nodding like this over the last year. And concerning the details and the deadlines, it feels like the goalposts have been moved on us. But you know, fortunately, right after this segment, we have Christine McCullough from LTC Solutions, who is going to be presenting on this very topic, and I would encourage everyone to tune into that item as well. Moving on to the next slide, the Consolidation Appropriations Act that was enacted by Congress and signed by President Trump December 27th of 2020. And this federal law, it contained, several price transparency requirements. The first one being called Transparency and Coverage, TIC, and then also protections for consumers from that balanced billing, known as the No Surprises Act. TIC, for the purposes of this update, will focus on that piece, and the transparency and coverage requirements. It has many different obligations that are spread out as it currently sits over a 3-year period. You'll see 22, 23, and 24 on the slide. Also important to note that the transparency rule is applicable for both fully insured health plans, like all the WCIF medical plans, but then also it's applicable for self-funded plans as well. However, one differentiator would be in the way in which these plans comply is different. So for instance, fully insured plans, the insurance carrier is going to assume the full responsibility for compliance, whereas the self-funded plans, although they can contract with different carriers, TPAs, or other solutions to help fulfill this requirement, ultimately, any liability for non-compliance, that does fall back on the plan. It does not fall on the contracted help that employers worked with. Slide 5, if you don't mind. regarding the effective date and the timeline, I mentioned just a minute ago as it sits, and that's because the federal government has already issued guidance that provided deferred enforcement dates for specific provisions that, that we collectively worked on the last time we met. First milestone, which we've already are aware of, we're well underway, and that went into effect January 1, 2022. And that first one is for plan ID cards. As you know, we were required to have specific details on our ID cards starting this effective date. They needed to be illustrated on every single person's ID card. And so for WCIF members, this was already addressed at our plan renewal back in January. And that triggered the ID card update for members, which satisfies the first of those 4 pieces. The next one that you'll see is a continuity of care, which what that is offering an employee an opportunity to elect a transitional period of continued care with a provider who was participating under the applicable network, but then they would transition out and no longer be within the network during the course of service. And so if you have certain medical conditions, you can qualify for this continuity of care. The language around it for examples of care, examples of conditions could be scheduled surgeries, pregnancies, inpatient care, if there's any kind of serious or complex conditions, and then terminal illness as well. The transitional period assigned can last up to 90 days from the date of notice or end prior if a member were to seek care from a different provider. So again, that's up to 90 days. Then we have the no surprise billing, which again, we're familiar with. Remember in the state of Washington, a year prior to this, we actually had the Washington State Balanced Billing Law that went into effect January 1 of 2021. So this is similar in nature. And then the provider directory. And what this does is it ensures the providers' directories are updated. So provider directory meaning online, that those are updated every 90 days. And then within 2 business days of receipt upon updated information, then the website needs to produce that as well. And so if someone were to seek services out of network because of what that provider directory said was incorrect, then they cannot be charged. That piece is interesting. Again, this went into effect in January, so it'll be interesting to see how that last component actually plays out and how someone would be providing proof around that. And then the next milestone that we have ahead of us here is just 3 months away. And that is a public access requirement with the 7/1/2022 effective date, machine readable files and MRFs. And so these need to be developed and then they need to be publicly posted and then disclosing 2 specific items. The first one is in-network rates with contracted providers. And then the second piece is out-of-network allowed amounts. And there was initially a third item that obligated the files to reflect pharmacy drug information. So the negotiated rates, historical net prices, historical prices at that specific pharmacy. And so when that had rolled out, it was something that we were all very, very interested in, but unfortunately that was removed. And so there's no longer that third requirement. It's really only around those two items that need to be met by July 1 of 2022. One comment about these machine readable files is that these really are geared for company to company info. It's not designed for the end users like you and I to look up and see what it means. Rather, it's for data analytic companies to use. Then moving on to December 27, 2022, health plans are to furnish health and prescription drug plan information for that 2020 and 2021 plan year. Insurers and plan must submit data on pharmacy benefits, drug costs, and submit that to the federal regulators on an annual basis. This data is going to include, for instance, the plan's 50 most costly drugs, and then 50 drugs with the greatest increase in plan expenditures year over year. total spending on the healthcare services. And I think from that perspective, there's going to be subcategories rather than just one blanket number on healthcare, and have that broken down. And then fees paid on premiums, and then rebates that pharmacies are supposedly sending back. So these are going to be huge data files. And then the information is going to be then compiled into a report that's publicly available biannually. And the role of the prescription drug costs in contributing to the premium of increases and decreases is supposed to be illustrated in this as well, which will be interesting. Again, we certainly haven't heard a lot on this topic yet. Right now, there's a lot of focus on this upcoming deadline of 7/1. So I think there's going to be a lot more to uncover in the coming months about this December deadline. And honestly, we'll see how firm of a deadline that is. We've already seen some components of this legislation be pushed back and delayed. So it's something that we're going to be continuing to watch. Looking ahead, 2023 and 2024 requirements around the total cost estimator tool, those have been produced. Plans and health insurance will need to provide members with a tool that enables them to do a cost sharing liability for that, for their healthcare services. And so the first phase is 500 of CMS design services, and that's going to be due in 2023. And then the second phase, which is all other services, is going to be due in 2024. And so with this data group, health plans must make available personalized out-of-pocket information, the underlying negotiated rates for services through an internet self-service tool, but then additionally, they're going to need to be able to provide these in paper upon request. And then additionally, we know that we have advanced EOBs ahead of us, post-service EOBs. This is just such a massive undertaking of legislation, and we're going to continue to see how this develops over the course of the year. Slide 6, transitioning now to mental health parity. A bit of background on mental health parity before we just dig right into the treatment limitations. Mental Health Parity and Addiction Equity Act, we'll call it MHPAEA. It was originally established in 2008, and then it expanded on the already laid groundwork from the Mental Health Parity Act, which I'm sure all of us are familiar with, and that had passed about 12 years prior to that. And so the original Mental Health Parity Act, it aimed to prevent large group health plans from placing any type of annual or even lifetime dollar limit on mental health benefits if those limits were less favorable than the ones that were already placed on medical and surgical benefits. So the MHPAEA of 2008, it did keep that original framework, and then it included benefits specifically designed for substance use disorders. So the MHPAEA itself, it doesn't require that health plans offer mental health and substance use treatment, but what it does, it says if a plan does cover this, which honestly the vast majority of plans do now, group health plans and individual plans, they do, generally speaking. The MHPAEA, it requires health plans to provide mental health and substance use disorder benefits in parity with medical surgical benefits. So in parity, meaning in the same amount, it cannot differ, it cannot be lower. Yeah, sorry, I guess the emphasis is that it cannot be lower than. And so with that, we look at the recently passed Consolidation Appropriations Act of 2021. And what that does is it requires health plans and issuers to document their compliance with MHPAEA. And specifically, the act does require documentation of 2 anti-discrimination tests, the NQTL, which is the non-quantitative treatment limitations test, and then the QTL, which is a qualitative treatments limitations test. Slide 7, the QTLs, they are more easily identifiable when you look at a benefit schedule and an SPD. They're the ones that show up with numbers of visits, limitations, hard dollar amounts, or even specific days of coverage limitations. It's the NQTLs that may not be entirely spelled out in an SPD, and they have to do with limits on the scope or duration of a plan, medical management processes, prior authorization, pre-certification, plan exclusions, step therapy. So again, not as easily identifiable. And so once those two are identified, then there is an analysis that's conducted, and it needs to be evaluated in several categories of benefits. You'll see on the left-hand slide there, inpatient services, both in and out of network. The same would be applied for outpatient in and out of network. And then also you need to look at emergency care and then prescription drugs. Again, you're analyzing the QTLs and the NQTLs to ensure that mental health benefits must be comparable to and applied no more stringently than those for medical surgical benefits. Then you'll see here on the slide the effective date of February 15 last year, back in 2021. And so we've had over a full year of this requirement in place, and auditing it has been conducted over the past 14 months. And what I can tell you is that of the plans audited, 100% of them failed. They failed on the analysis. And so that's not to say that every single plan is operating the health plan incorrectly under the Mental Health Parity Act, but what it's saying is that they're failing on how accurately they're documenting the compliance. This process itself, it aims to document parity, or in this case, lack thereof, and then demonstrate whether the health plan compliantly applies the benefit limitations in parity with respect to the mental health and substance use disorder benefits. As made evident by the failed audits, it is critical to understand that performing the analysis, yes, that is one piece. But then what's equally important is the accompanying piece of documenting this analysis. So in other words, you have to show your work. It's been published that agencies are going to request a minimum of 20 analyses per year, and then plans have to have the comparative analysis upon request. We've been working closely with insurance carriers to ensure that this area is going to be satisfied, and that does include Premera and Kaiser, especially in the event of an audit, which we'll touch on that in a few slides. Moving on to number 8, at-home COVID-19 tests. This one was a whirlwind. Back in January, the federal government required group health plans cover over-the-counter self-administered COVID-19 tests at 100%. There could not be any kind of upfront costs, copay shares, or even medical criteria around this. And if my memory serves correctly, the parameters for requiring the health insurer plan sponsors, that was published, it was on a Monday afternoon, which I think was January 10th. And then they were required to take action by that January 15th date, which I think was a Saturday. So less than a full business week to do that. And in speaking with a few pharmaceutical companies, what was really unique about this was generally when the parameters and rules, when they're first established, there's this window of time that the companies can then digest the information, share with their legal team, and then come up with a strategy and a plan to roll it out. Especially around this piece, when it was apparent that there's probably going to be a new network that needed to be created. But with this one, there's just a matter of days to just digest the information, create a plan, communicate it out to the employers and plan sponsors, who are then supposed to take that information and then try to get it out to members in basically what was 4 business days. As you're aware, the requirements allowed for each covered member to order up to 8 tests per month, which is straightforward enough. But at the time, there were a few obstacles that impacted the rollout here. One being there was a national shortage of COVID-19 tests, just in general. And then 2, kind of somewhat related to the shortage, was there was a widespread of costs per test. We saw anywhere from $12 all the way up to $150 per test, which obviously creates a lot of concern around the cost when each enrolled member could theoretically obtain 8 tests if you could find it per month, which would be then 96 per year. And then you take that even further and you think about a family of 4 who could have up to 32 a month or 384 per year, which is a lot. So then third, that other item is to then try and help rein in the cost exposure. The guidelines did illustrate the ability to create what they're calling a safe harbor network, where tests could be limited to up to $12 per test reimbursement, which was a certainly helpful measure. Though recall what I talked about, pharmaceutical companies, they only had 4 business days to respond. Please don't mistake that for me feeling bad for pharmaceutical companies. That's not the case at all, but rather the tight timeline, it resulted in a financial exposure for plan sponsors if they couldn't limit the cost of tests right away. And then fourth, there was a lot of concern around volume and the purpose of usage. It was established that the tests were only used for personal use and generally wouldn't be accepted for institutions that required proof of a negative test. But again, there was no way to truly enforce that. And then what crept into our mind too was that hoarding effect. If you could find tests, how are people going to take all of them? You know, much like we saw in 2020 with toilet paper. It was concerning, to say the least. Again, this was a federal regulation, so there was no question if insurers or health plans wanted to comply. It was required. There was no consideration there. But because of the many variables that were present at the time, it became more so of a strategic conversation in how we were going to comply. Fast forward to today, and a lot of these concerns that we've talked about, they truly were quickly tempered. We're not experiencing the same national shortage of COVID-19 tests that we were. The tests themselves, regardless of where you got them, generally they started to run back to that $12 per test limit. And then also pharmaceutical companies and pharmacies, they were able to set up their network, safe harbor networks within just a few weeks, all the way up to a month. From that January 15th effective date. Transitioning now to some Washington state specific measures. We have the House Bill 2662 and Senate Bill 6087 on insulin cost sharing cap mandates, insulin affordability. Nearly 1 in 8 adults in the state of Washington have diabetes, and then 1 in 3 of those use insulin. And this is according to the Washington State DOH, Department of Health. And since the early 2000s, we have seen that insulin has increased almost 3 times the amount over this course of time. And so it was this statistics, this information, this increasing cost that led to the Washington State insulin affordability back in April of 2020. And this bill was signed into law, and ultimately it limited the total out-of-pocket cost that a member could pay towards insulin to $100 per 30-day supply. This bill had an effective date of January 1, 2021. So again, this went into effect last year in the state of Washington. It's important to note that this $100 cost share limit, it's regardless of plan structure or style. So that could be you have a high deductible health plan or a high coinsurance tied to pharmacy. Again, that has to be waived. It's only $100 that could be enforced. And then furthermore, that $100 that you pay towards the copay, it must have been applied to any type of added deductible out-of-pocket maximum. Next slide, slide 10. Just last month, Senate Bill 5546 was passed. And so it dovetails off the expiration of the prior legislation that we just talked about that had an end date of December 31, 2022. And it's going to further limit the copay amount from that $100 that we have right now down to a $35 copay per 30-day supply of insulin. No, this is applicable for everyone in state regulated insurance plans, fully insured plans, just like the WCIF, Premera, and Kaiser plans that we have in place today. Much like the current legislation in effect, that $35 copay is going to apply to insulin regardless of plan style. So even if you're on a high deductible plan, and then they must also be credited to deductibles and out-of-pocket maximums as well. Just to highlight one piece on this, this legislation, it's only applicable for insulin. And so other items related to this, like insulin pumps or glucose monitoring supplies, those costs are going to continue to be in addition to. It's not impacted by this $100 cap, or now $35 cap. One really key component to take away from this cost of insulin is that the copay and the cost to the end user, that is capped. But what this legislation does not impact is the actual cost of insulin from the manufacturer, who are the ones that are increasing, that have given us the 3 times the cost since the early 2000s. So in other words, the manufacturer is still able to charge that same amount and that same price. It's just the end user is now has less of a copay. That means in the middle, the plan sponsors, you're still paying for the insulin. And so although this legislation, it is a good step for end users, it doesn't really get at the heart of the issue, which is the increase in manufacturing costs. Slide 11, the PAL, Partnership Access Lines Assessment. This is an assessment-based funding program that supports 4 major areas. First is the Partnership Access Lines. And what that is, if you're unfamiliar, is the PAL. It supports primary care providers with questions about children's mental health or diagnosis clarification, medication adjustments, or even treatment planning. The second piece is mental health referral services for children and teens. And then we have perinatal psychiatric consultation line for providers, support for moms. And then fourth is psychiatric consultation line. And in 2020, the legislature passed a bill that directed the healthcare authority to collect a covered lives-based assessment from Washington state health insurers to keep this PAL up and running. And so from there, then the HCA contracted with KidVax, who acts as a third-party administrator to calculate and administer the Washington PAL funds assessment. The first reporting period, it was in effect last year, starting January 1 through September 30th of 2021. That was the first reporting period. And then the first payment date was thereafter on November 15th. And then so the payment cadence is going to follow 45 days, calendar days after the close of each quarter. In order to calculate the correct payment, employers must accompany the supporting data or the headcount with the payment in a very specific format. This was unique to other costs that we've seen in the past. The headcount is remitted actually upon age categories. So submitters needed to provide 3 age bands. The first one is a child covered lives, so between 0 and 18. And then there was an adult age band, 19 to 64. And then the third adult age band was going to be 65 and plus. And so since this assessment is computed on a per lives per month basis, the payer quarterly reporting obligations are going to show a total of 9 numbers. The covered lives total for each of the 3 months, and then each of the 3 age bands as well. One thing that's important to note, at the onset of this program, the estimated friend requirement, it penciled out to be about 13 cents PEPM. So an annual cost is $1.56. Which was remitted again. The first payment was back in November 15th of 2021, excuse me. As we geared up for employers and started helping them calculating their amounts for the payment that was due this February, so just a few months, it was released that actually the estimated cost, that 13 cents, it was too high. And so for the next payments, it was actually going to be decreased down to about 7 cents per month. And you can think of that as a 46% off. And so that was something that was certainly well welcomed. It doesn't always happen, so absolutely worth calling out. On to slide 12. Lastly, we have Senate Bill 5313, and this is a Washington State gender affirmation mandate. On May 12th of 2021, there was Senate Bill 5315, and it was signed into law. And this new law was in effect just a few months ago at the start of the plan year, January 1, 2022. And it imposed several requirements on health plans and health insurers regarding gender affirming treatment related to gender expression and or identity. And health plans are prohibited from denying or limiting coverage for gender affirming treatment when prescribed to someone because of related to or consistent to their gender identity. And also as long as it is deemed medically necessary and is prescribed in accordance with accepted standards of care. And so in practice, what this actually means is that the requirements include reviewing and updating medical policies, also plan coverage and plan booklets to remove any kind of categorical or blanket exclusions like there has been in the past, specifically to cosmetic treatment. So I guess in other words, since the gender affirming services became a covered benefit a handful of years ago, it has always been excluded or denied coverage for services if they were of a cosmetic nature. Things like facial bone reconstruction, facial augmentations, liposuction, implants, all those things, they were not eligible services until now the rollout of the state requirement, which again went in effect 1/1 of 2022. This is going to be 4 groups that are renewing in 2022. So it's going to apply to all the fully insured plans. The WCIF, Premera, and Kaiser plans have already made this adjustment for 2022 at that renewal and are currently in effect for all of our active plans. Now on to the last slide. Thank you so much for hanging in there with me. I know I'm close to time here, so I will speak quickly. We thought it would be helpful to conclude with a slide, just a roll up page that highlights the major legislative topics that we addressed and then how WCIF and our 2 medical partners are maintaining compliance. First, recall in Washington State, prior to the No Surprises Act, we had rolled out our own Balanced Billing Protection Act that applied to fully insured plans, including the WCIF, Premera, and Kaiser plans. So now that the federal No Surprises Act is in effect, both carriers have assured compliance to the regulations on behalf of members and will continue to do so. So those 2 get a check. Then the TIC, transparency and coverage. Both carrier partners, they have acknowledged the multi-year requirements and provided their commitment to organizations that they're going to follow the federal guidelines and remain compliant. As you know, we've already seen our ID cards, and so we've met that box. And then next, they're both gearing up for that 7/1/2022 machine readable file date ahead of us, where they can debut those files. And then treatment limitations. At a high level, both carriers, they have acknowledged the obligation to comply on behalf of fully insured plans, and then are establishing and in the process of taking those and developing them into a comprehensive disclosure that demonstrates parity for each non-quantitative treatment limitation, those NQTLs. For WCIF Kaiser plan specifically, they're currently evaluating its comparative analysis for improvement. Again, there have been changes around this, and so they want to confirm that they're prepared to respond appropriately to regulatory inquiry should that arise. And then Premera, they have produced the analysis, and it documents Premera's own process for designing the benefit plans and how they apply prior authorization and that medical management criteria. And that analysis is ready, but just like Kaiser too, again, they're keeping their eye on the structure, the format, and then making any changements as deemed necessary to ensure that everyone is capable of passing an audit. At-home COVID-19 tests, as you're aware, both Premera and Kaiser have had solutions in place to comply with federal requirements dating back to January 15th, 2022, excuse me. And then we have on there insulin affordability. This was initially satisfied with the rollout last year with the state cap at $100. As you know, that does expire this year. And then next, it would be the $35 cap that's going to take effect in 2023. Both Kaiser and Premera confirmed that they're aware of it, and they're going to make the updated adjustments come 23 when it is in full effect. partnership access lines fee, the PAL fee. This has been in effect, as we talked about, since the first payment was due back in last Q4. Premera and Kaiser, they did assess the appropriate fee per head based on their book of business, and then they actually pay it on behalf of WCIF members. Note when I say that they pay it on behalf, I mean that they do the mechanics of it. So they're doing the calculating, the appropriate fee, they're submitting it, and hitting that quarterly cadence. The actual costs, though, as you know, those are a pass through to employers, very much like we saw with the PCORI fee. But at least Premera and Kaiser have and will continue to check that box on behalf of WCIF. And then lastly, gender affirmation expansion benefit. Both of these have been addressed by Kaiser and Premera, and they're actively reflecting in our 2022 contract language and booklets. Practically speaking, the changes that were made was they took out the blanket exclusions in there, so that cosmetic nature exclusion no longer applies. As WCIF employer participating employers in either Premera or Kaiser, it's our hope that you can rest assured knowing that we all view compliance as a critically important component of your benefit plan, and we really are committed to the continual adherence of the law, and we want to keep you apprised as things develop along the way. So with that, I thank you for your time.
That's good stuff, Ashton. Thanks so much. We appreciate it. And